Thank you very much for taking your time to be a part of today's talk. Today's talk will be on OCD and it is titled Thoughts You Can't Stop and Acts You Cannot Control. I repeat, thoughts you can't stop and acts you can't control. So, this is one trait that we see in few people, and it's a little confusing when we see and we do not know how to deal with it. So, OCD is a common mental disorder affecting nearly 1% of the population in India. It is a chronic disorder causing significant dysfunction in the affected person's life and also their family members. Understanding of the illness and treatments available is very necessary, or else it's going to make things hard. And in this session, you'll be able to understand and learn about the symptoms that comes when you see or when you understand the OCD trait, and also you can also learn about the possible causes for those things and also the required treatment process for it. So this is what OCD is about. That's all what I know. I do not know much, but to deal with this and to talk more on this and to enlighten us on this, we have Dr. Vidhya Sagar amongst us. And Dr. Vidhya Sagar, thank you very much for taking your time. And to know a little more about who Dr. Vidhya Sagar is, he has he has 7 years of experience in psychotherapy, both adult, child, and families, and also he is an expert in psychometry and neuropsychology. Those are fields which I've never touched or which I actually do not know anything about. So I'm pretty sure Dr. Vidyasagar will be able to enlighten us on that. On he has done research on anxiety disorders, emotions and emotion regulation, and movement disorders. He specializes in cognitive behavior therapy for all stress-related disorders, be it anxiety, mood disorders, PTSD, etc., and all. Substance abuse, behavioral and technological addictions, personality disorders, and couple therapy are the few fields that Dr. Vidya Sagar specializes in. And he has conducted about 25 workshops on parenting. Wonderful. I hope I'll be able to invite him soon for my parents. Just kidding. Managing relationships for youth, stress management, wonderful. Emotion regulation, CBT for specific anxiety disorders, emotion focused therapy, and many more vital topics that are very, very required for the youth and the elders of today. So he has a PhD in clinical psychology from the NIMHANS Bangalore, and also he has MPhil in clinical psychology from the same institute in Bangalore. So he is a person who is loaded with information, loaded with experience. So I request you all and I urge you all to pay close attention to what doctor is going to say today. And we'll be having a Q&A post his talk. So as you listen, I hope you'll be able to recall few instances in your life that is related to this topic, and you will post out your questions in the chat box post his talk, and Dr. Vidya Sagar will deal with it. Dr. Vidya Sagar, we are very glad to have you. It's your time. Over to you. Thank you.
Okay. So, so we are going to talk about OCD, obsessive compulsive disorder. What are the symptoms? What are the causes? And what are the different treatments that are available for OCD? Okay. So, as the name implies, OCD is basically obsessions are thoughts that you cannot stop, that you find difficult to control, and acts that you cannot control. Okay. I think some of you might have had experience working with these people, or some of you might be suffering with maybe a few or a few of these symptoms. So I hope at least this would give you an overall understanding of what OCD is, and if you are suffering with it, and it will provide you with some hope. Okay, so that treatments are available, and you can get better with the treatment. Okay, so is it clear? My voice is clear, or okay, great. Just a second. Yeah. So, what are obsessions? OCD basically involves obsessive compulsive disorder. Okay. So, what are obsessions and what are compulsions? So, obsessions have a specific nature to them. So, they are unwanted, intrusive thoughts, doubts, or images or urges. It can be anything which is intrusive in nature. They can be thoughts, they can be doubts, they can be images, or they can be urges. They repeatedly enter into the person's mind, and they cause distress to the individual, and they are ego dystonic in nature. That is, the person views these thoughts or behaviors as inconsistent with his or her personality. So the recognition that these are inconsistent with one personality is one of the main aspect of obsessions, and the person acknowledges that these thoughts or urges or images, they are originating in his mind. They are not coming from any external agency or from outside. And they also regard these thoughts or urges as unreasonable or excessive, and most of them they try to resist them, but they fail most of the times, and it is considered chronic. Okay. And so the basic difference between, suppose you might have some intrusive thoughts which are not distressing, which are repetitive in nature, which they come to your mind, but you enjoy those thoughts. Okay. Then they are not obsessions. And we all worry from time to time, that we have a lot of worries about day to day things, so which can be repetitive in nature, but you don't consider them as unreasonable. Okay. Or you don't consider them as excessive. Okay. Sometimes worries can become obsessions, but they become obsessive worries. So but then the difference between obsessions and worries is that in obsessions the person understands that they are unreasonable. Okay. They are irrational and excessive. Okay. Whereas worries are mostly related to our day to day life events. Okay. So this is basically obsession and how you need to differentiate with other forms of thought. Now coming to compulsions. Okay. So because these obsessions they cause lot of distress to the individual tries to get rid of that distress or anxiety that is caused by these thoughts. So compulsions are repetitive behaviors or mental acts. They can be overt behaviors or they can be covert acts or covert processes that the person feels driven or compelled to perform. Okay. A compulsion reduces the distress that the individual is experiencing, and it reduces that distress temporarily. Okay. A compulsion itself is not pleasurable. That is, the person does not enjoy doing the compulsion, because compulsions can take about 1 to 2 hours or maybe 4 hours in a day also at a stretch. So compulsion is not in itself pleasurable, which differentiates it from impulsive acts that we do, such as shopping, gambling, so that are associated with immediate gratification, giving immediate pleasure to us. So that is basically compulsion. So basically, thoughts are repetitive. Obsessions are repetitive thoughts, urges, or images, whereas compulsions are repetitive acts. Okay. So you will see some of the examples. I am going to present a case, so when you see that case you will be able to understand it. So for the benefit of those who could not hear, obsessions are repetitive thoughts, urges, or images, okay, which come into a person's mind without their wish. Okay. But they that means they are intrusive, and person recognizes them as irrational or unreasonable, and they cause significant distress to the individual, and they would try to avoid them, but they fail miserably. Whereas compulsions are the repeated acts, which can be overt behaviors or mental acts, which the individual feels compelled to perform in order to reduce the distress that is caused by compulsions. Okay. Caused by obsessions. Now how prevalent is this disease or disorder in the population? And we will have a look at some epidemiological aspects of obsessive compulsive disorder. So according to National Institute of Mental Health and Neurosciences, NIMHANS, according to their survey, a comprehensive survey, 1% of Indian population is suffering with OCD. Okay. Obsessive compulsive disorder. And this percentage is high, from 2 to 3% in other countries like USA. And this disorder is highly prevalent among individuals between 8 and 30 years. Okay. And usually the onset is also seen during these years. That means the beginning of the disease is usually seen in these years. And this fact has a significant uh, impact on whether the person is going to improve, what is the probability of prognosis. For example, if the onset is earlier than this, before 80 years, 18 years, or if the onset is very late, maybe after 40 years, so you can consider that the prognosis is poor. So the chances of person becoming better is poor if the illness has started before 18 years or after 30 years, most probably after 40 years. Okay, and even in studies it was found that the prevalence of OCD is higher in women compared to men. Okay, these are few facts that are found in research, survey research. Okay, so what are the different types of OCD, or what are the different symptoms that are experienced by individuals who are suffering with OCD? Uh, okay, so there are common symptoms like fear of contamination. Okay, that I get repeated thoughts that I am contaminated with dirt or some fluids. It could be body fluids also. So that creates a lot of anxiety in the person, and they engage in repetitive or compulsive washing. And they also have pathological doubts, like whether I have switched off something, whether I did something or not. So they repeatedly check. That becomes the compulsion. And they also have thoughts about harming other people. They might have blasphemous thoughts. They might have intrusive sexual images or thoughts. It can be sometimes they experience these thoughts against children, these thoughts against gods. So they are called taboo thoughts. Okay, and they also perform a lot of compulsions. So washing, checking, they are all overt compulsions, but they also perform compulsions in their mind. So they are called cognitive compulsions. Okay, so uh, the OCD can be of two types. Okay, they can be either predominantly obsessive, that they display purely obsessions. You may not see any compulsions being performed by that individual, and or it can be predominantly compulsive. You don't see many thoughts reported by that individual, but they predominantly perform compulsions. Okay, so but this pure obsessive or pure compulsive disorder is not that common. So what we commonly see in our practice is it is mixed OCD, where they have obsessions as well as compulsions. Okay, so one of the important aspect when you deal with OCD is whether they have an insight. Okay, so if you remember in the definition of obsessions, uh, one thing that I mentioned is they need to understand, to consider something as obsession, that they have an understanding that these thoughts, repetitive thoughts, urges, or images, they consider them as unreasonable. So that they have an insight that they are unreasonable, they are silly. But if they lack that insight, so there is a possibility that they lack that insight, that they don't understand, they consider them as truths, they consider them as real. So that's when we call it poor insight. So studies have shown that nearly 25% of population suffering with OCD, they have poor insight. So what does it mean? People who have poor insight, it is very difficult to treat them. Okay, and they have a poor prognosis. Okay, so it difficult to treat as well as poor prognosis. Sometimes individual vary in the level of insight that they have. What do I mean by that? So at certain phases of the illness they might have good insight, and at certain other phases when they are maybe extremely stressed, when these symptoms are severe, they might lose that insight. So the insight is also fluctuating. So as I said, there are other symptom dimensions like forbidden or taboo thoughts. There are also thoughts related or obsessions related to symmetry, ordering things, compulsively keeping things orderly, organized. Okay, and there are also symptoms related to hoarding, compulsively hoarding or collecting things which are beyond need. Okay, and yeah, so there is one particular instrument or scale that is used, which is called Y box, so which is freely available online, and if you are interested you can check it. Ale Brown obsessive compulsive scale, it is called Ale Brown's obsessive compulsive scale. So you can check, they have given list of symptoms. It is commonly used across all people suffering with OCD in order to assess the symptom dimensions as well as severity of the illness and insight. Okay. Yeah. And some of the examples, like the kind of thoughts these people get repeatedly, like I may harm my child with knife, I may run over someone while driving, I may hang myself, I may cause a fire accident by not being careful enough. And they keep getting violent or horrific images. They also have thoughts like I may blurt obscenities or insult while talking to somebody. And they also feel the need to repeat routine activities to prevent terrible consequences. So they might also get thoughts like am I gay, am I pedophile, and they also get thoughts of molesting children. They also have sexual thoughts or images of family members. So one of the predominant symptom that is seen in specifically in Indian population is they have urge to look at private parts, and they also have these abusive words against God in the form of a thought in their mind. They also have sexual images of gods. These three symptoms are particularly seen in Indian population. We don't know why, but this is what observed. Okay. And they also have thoughts like I have not prayed it correctly, I have not prayed correctly. Okay. So these thoughts repeatedly coming to their mind, they create a lot of anxiety in these people. So they engage in some compulsions or repetitive acts. Okay. So we will have we will have look at examples of some of these compulsions. So these compulsions, we also call them neutralizing behaviors because they are used to neutralize the anxiety that is created by these obsessions. So these compulsions can be repetitive or excessive washing, repetitive checking, silent praying, repeatedly asking for forgiveness or reassurance, mentally arguing in their mind, or mentally sorting out those thoughts, or mentally going over each and every aspect in their mind, or also saying aloud certain phrases to undo blasphemous word or obscene words that came to their mind, and they try to balance them with correct thought or image, silently counting numbers. They so each one has their own specific number. Some might count 9, some might count 3, some might count 13, some people even count 200, 300 till they finish. They don't do anything. So they can also have checking related compulsions, and along with compulsions they also engaging a lot of avoidance behaviors. For example, if I have compulsion of washing, since if I start a particular activity of washing, I need to continue to do it for a long period of time. What I do is I completely avoid washing. So there is also a lot of avoidance that these people engage in. Okay. So one of the other thing that you will also find in people with OCD is something called proxy compulsions. Okay. Or proxy avoidance. What do I mean by proxy? So they make their family members do compulsions for them. They make family members to avoid certain things. Okay. They are called proxy compulsions and avoidance. So we call this phenomena family accommodation. I repeat, it is called family accommodation. So that is, family members are changing their behavior in order to accommodate the symptoms of the person. So in the research, it was found that if the family is accommodating, so it can maintain the illness, it can stop or it can reduce the effectiveness of the treatment process. Yeah. So proxy compulsions and avoidance, and since it causes significant amount of anxiety, OCD, over a period of time, individuals with OCD would develop other psychological issues. For example, one of the predominant thing that you need to look for if somebody is having OCD for a chronic period of time is whether they have any suicidal tendencies. So which is common in OCD, but usually it is often ignored. Okay. So one need to ask for it and one need to look for it. So and you also see predominantly depression and other anxiety related issues. Okay. And you also see some personality disorders in people with OCD. Okay. So now depression is most often it is secondary to obsessive compulsive disorder, because I mean, they would have struggled with OCD for a long period of time. Now they don't see any hope. Okay, because of this hopelessness, their negative thinking process that is triggered by the chronic nature of the illness, they develop depression. And if they develop depression, it becomes again complex to treat the illness. Once first you need to treat the depression, then again you need to treat OCD. And usually you also see that around 30 to 40% of around 30% of the people with OCD also have other anxiety disorder, like they might have social anxiety, they might have panic disorder. Okay, so one of the important thing is you need to see whether they have pure only one single form of OCD, or they have any comorbid illnesses. So presence of comorbid illnesses is a poor prognostic factor. So if they have another illness, it makes the prognosis poor. That is, they are less likely to improve compared to somebody who has only OCD. Okay. Now, what are the causes of this illness? Okay. So till now, I mean, whatever the research that happened, there are many theories and many findings that indicate that they are related to, they are associated with the development of OCD, but there is no cause and effect relationship established. Okay, so there are many factors that were found to be associated with, or that were found in people with OCD. Okay, but you cannot pinpointedly say that this is the cause of that illness. Okay, so I mean, the factors that are associated with the development of this illness can be divided into, let's say, biological or psychological. So if biological, if you look at biological genetic, in the sense if they have any family history of any psychiatric disorder, that actually puts them at a vulnerable position to develop any psychiatric disorder. It is not specific to OCD, but having a genetic loading, or having somebody with some psychiatric disorder, is also considered one of the reason for developing OCD. Okay, so they may develop any other psychiatric problem. Okay, and it was also found that there are structural abnormalities or functional abnormalities in some of the brain structures. For example, one of the brain structure, that is our pathway, we call it corticostriatal pathway. Okay, so cerebral cortex, orbitofrontal cortex to striatum. Okay, so there is a pathway, like there is a network that function the functioning in that network is abnormal, that is noted in biological causes. And there are also neurochemical imbalance, particular neurochemical imbalance that that was noticed is lower levels of neurochemical called serotonin. Okay, or serotonin. So they found that there is a deficiency of serotonin in individuals who are suffering with OCD. At the same time, there are also psychological explanations for why people develop OCD. Okay, one of the explanation is it is developed through conditioning or learning. Okay, so like learning is basically one a response that is associated, or by pairing up of some association, or pairing up of two events. So they are learned to occur, the person learns to associate that this particular event is associated with the sec- the event that is associated with that. For example, if a dog salivates when a food is food is brought to its place, so it is a normal response to food. The salivation is a normal response to food. Okay, but every time that food is given, you ring a bell. Every time that food is given, you ring a bell. So dog learns to associate food with the bell. Okay, so when you do that multiple times, and after that you present only bell, so it also salivates. So now it has learned to salivate to bell, not to food. Okay, even in the absence of food, only to bell it salivate. This process of pairing and making a animal, or the what animal learned through pairing of two things, is called conditioning. Okay, so once it conditioned, through a process of reinforcement, it is being maintained. Okay, so what is reinforcement? So reinforcement is basically a reward. Okay, for example, if you are now you are all sitting in a chair, in your chair, and imagine that a mild electric shock is given to the chairs that you are sitting. So you won't continue to sit in the chair because it is painful. What you do, you immediately get out of your chairs. So what happens if you immediately get out of your chairs? You are relieved from the pain that is caused by the shock. So that means whenever you experience the similar thing, in order to relieve, you found a way now. So you would continue to do that. So these people also, when they experience anxiety, what they do is they perform compulsions. When they perform compulsions, it gives them a temporary relief. So that means the performing compulsions has taken away the anxiety experienced by these people. Okay, so that's how it is reinforcing for them. So whenever they experience distress again, they perform it again. Whenever they experience distress or anxiety again, they perform it again. Over a period of time, it becomes a strong learning. Okay, like any other form of addiction. Okay, so this is one way of understanding how people develop a particular behavior and how it is being maintained. Now the second way of looking at things is because of dysfunctional appraisals, dysfunctional ways of understanding one's own experiences or events. So it is not because of the event, it is because of how you understand the event. You would develop psychological issues. If your understanding is dysfunctional, you would develop psychological issues. Okay, so we will talk about some of these dysfunctional appraisals and you will understand then. And if somebody is going to severe stress and they are already vulnerable to develop any psychiatric problem because of the genetic loading or because of their temperament, there is a possibility that they would develop any psychiatric disorder. Okay, and as we have discussed, family pathology. So somebody is having already an anxiety disorder, and even their parenting is also like if the parents are anxious, you will easily learn anxiety from them. You will observe them and learn. You will understand that things are not safe in the world. Okay, so you will try to exercise cautious behavior whenever whatever you do something. So family pathology also can contribute to the development of OCD. Okay, so there are biological as well as psychological. Now, what is the treatment that is available? Okay, what are the different forms of treatment that is available? If you look at causes, so the treatment, I mean, based on the causes, the treatment should address all these causes, right? So biological causes can be addressed by pharmacological treatment. Psychological causes can be addressed by psychotherapy. Okay, so we look at treatment like for biological causes, the main line of treatment is using SSRIs. SSRIs are nothing but a particular category of drugs which are called selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors. So basically what they do is they make sure that the serotonin balance is maintained. Serotonin is a neurochemical, its balance is maintained. So whereas psychotherapy basically addresses the causes of psychological causes. So CBT, cognitive behavior therapy, addresses these behavioral like learning related issues as well as cognitive appraisals. So one other form of CBT that is being used nowadays is called mindful based cognitive behavior therapy. Okay, so there are also some surgical what do you call treatments available. One is psychosurgery, which removes the part that is assumed to be or that is found to be responsible for OCD. Okay, so surgically they remove a particular brain area which is deep in the brain, so that they won't experience these repeated thoughts and compulsions. There is also something called deep brain stimulation. Okay, so by stimulating a particular area of the brain, so they improve the functioning of that particular area by activating it or by deactivating it. So deep brain stimulation is also one of the options, but they are considered last line of options because they include invasive procedures. They can cause a lot of side effects if they damage other parts of the brain. So they are considered last line of treatments. But even for them, till now the evidence is not so good. Okay, so this is the basic treatment that is available. So I would not be going into what you call this treatment aspect, pharmacological treatment aspect, but I would be talking about what do we do in cognitive behavior therapy. Okay, there are different models in cognitive behavior therapy that is applied, but the basic assumption of cognitive behavior therapy is our psychological problems are the result of dysfunctional ways of thinking. Okay, so if it is because of the dysfunctional ways of thinking, you help the patient identify those dysfunctional ways of thinking and help them to correct those dysfunctional ways of thinking. So you need to identify what are the dysfunctional beliefs or thought processes these individuals are having, and how they are interpreting different situations. Okay, so there are different models. For example, there is a model called cognitive biobehavioral model. Okay, and the other model is called cognitive appraisal model. So the list of things that are given under this inflated sense of responsibility, overestimation of threat, they're all called different cognitive appraisals. And so in the research it was found that these are the appraisals that are used by people who are suffering with OCD. Okay, so we will look at some of the examples of these appraisals, and you will be able to understand this particular aspect. Okay, now coming to what is cognitive biobehavioral model. So which is a combination of cognition as well as biological aspects. So what you do is you take into account a medical model of the illness, medical understanding of the illness, and you incorporate it as part of the treatment. So what you say is, when you are getting repetitive thoughts, you tell the client, since you have OCD, since there is abnormality in the brain structure or functioning, you are getting these OCD thoughts, or you are getting these obsessive thoughts. So basically you are saying that is, in other people also get these thoughts, but they have a mechanism that is available in the brain that helps them ignore, but that mechanism is not working in you because you have OCD. So instead of giving too much importance to the thought, you help the client to relabel it. Okay, you help the client relabel it as saying that this thought is not my thought, this thought doesn't mean anything, this is because of OCD. So you help them ignore those thoughts. So this is done over a few sessions, maybe 3 to 4 sessions. So that is one way of dealing with the problem. Okay, so we say OCD is a biomedical disease. There is a particular circuitry which is malfunctioning. So that is why you are getting these things. So if you because you are having problems because of the structural abnormalities, you are having problems in your behavior. What you do is you change your behavior, and it in turn changes your brain. Okay, so how can you change your behavior? You can change your behavior by ignoring these thoughts, by relabeling whenever these thoughts come. Instead of taking them as it is and believing in them, you say that this is because of OCD. It does not mean anything. Okay, it is not a reflection of my character. So that's what you relabel. Okay, so the basic strategies are, you say that you emphasize that OCD is a brain disease. Okay, and obsessions are symptoms because particular area of the brain is not functioning well. So what you do is you become an impartial spectator of your thoughts. Don't give too much importance to the thought. These thoughts mean nothing. Okay, all they mean is that you have OCD. So these thoughts do not have any hidden meaning, like it doesn't mean that you really mean to do those things. Okay, so that is what basically you have to do. In most cases, if you give proper education about this illness, they would improve. Okay, if they have mild to moderate levels of illness, just by proper education and giving this understanding, uh, I mean in a didactical basis, like in a session basis, they will definitely improve. But if it is moderate to severe, if there are problems with insight, then you have to use additional techniques. Okay, now there are also other what do you call uh, other way of looking at these things is, there are 4 R's. Okay, one is relabel uh, uh, these thoughts as OCD, which is a brain disease. Reattribute them to the illness, and you try to refocus. Okay, you turn your attention away from this, and you also revalue. Okay, so basically whatever I explained, I have just put it in 4 terms. So this was developed by somebody called Brainlock. Brainlock is a famous self-help book that is used I mean, that basically we give to client, we ask them to read it in order to have a different perspective of their illness. Okay. And there is also a different model that we use, like for example, what happens in a person with OCD when they experience these OCD thoughts or obsessive thoughts. Okay, what are obsessive thoughts? Again, they are intrusive, repetitive thoughts, images, urges. Okay. Now, somebody get a thought that is trigger, so it starts with a thought coming into their mind. Okay. When the thought comes to their mind, they apprise that thought, like they give meaning to that thought. Like, getting thought is equal to or if I get a thought of a sexual thought, it means I am going to do that. Okay. If I get a thought means I am immoral person, I am evil person. So these are the meanings that are given to that particular thought. There are many appraisals, so which actually creates anxiety and panic. Okay. So when they get anxiety and panic, they try to suppress it, they try to control it, but they fail. Okay. And they perform compulsions, they seek reassurance, they avoid things, which actually reduces their anxiety temporarily. But it will not end there, but immediately after some time they again get one more trigger or one more thought, so it becomes a cycle. So one of the things that you do as part of the therapy is to break this cycle. Okay. Where do you break this cycle? You break this cycle at the level of appraisal of thoughts, or you break this cycle at the level of compulsions also. Okay. Now we will have a look at appraisals or dysfunctional ways of thinking about these thoughts. Okay. Getting thoughts is not a problem, but how the person deals with those thoughts is something that causes problems according to CBT. Now we will look at some of the ways individuals with OCD deal with these thoughts. Okay. Now, one of the dysfunctional way, we call it overestimation of threat. So like estimating threat than it really is. And there is only a 20% of threat, but I estimate it as having 100% of chances. Okay. For example, if I shake a stranger's hand, then I will contract AIDS. Okay. It is overestimation of threat. If I left the car unlocked, then someone will definitely steal it. Okay. There is definitely a possibility, but their estimation of probability is very very high, so probably it would be 100%. Okay. So thought action fusion, like if I think my friend is having an accident, then he is more likely to have accident. Okay. So that means they are giving importance to thought also. Getting thought is equal to this becoming happening. Thinking that I might have sexually touched a child is almost as doing it. Okay. It's like getting thought is equal to doing it. So we call it thought action fusion. Now there is something called inflated sense of responsibility. So they have extreme sense of responsibility, right? I must make sure that I don't contaminate other people, so I need to be clean, so I need to wash myself. Okay. Otherwise I'll be responsible if something happens to other people. If I get a thought of hurting others, I must do everything to prevent it from happening. Okay. Then over importance to the thoughts that they are getting. If I have a violent thought against others, maybe deep down I want to harm them. Okay. So I got this thought, that means there is really an intention in me to do that thing. I get blasphemous thought, that means I must be an evil person. So these are the ways that they interpret the thoughts that they come to their mind, which creates a lot of anxiety. Now you can actually correct these things so that they can be stopped at this thought level. So we focus on changing these appraisals, helping them understand that how irrational are these thoughts. Okay. There is also control of thoughts, like if I don't control these thoughts, I may go crazy, I become overwhelmed with anxiety. If I control these thoughts, I am less likely to act upon them. So they try to control, suppress, avoid thoughts. But what the research shows is the more you try to control them, the more you have them. Okay. So this strategy is going to backfire on them. And there is also something called inability to tolerate uncertainty. So I want everything to be certain, which is not at all possible in anyone's case, even in our case also. If I have a doubt, I must keep going over and over it until I am convinced beyond doubt that it was right one. I need to be absolutely certain that I did not make mistake in filling the form. So if I am uncertain, I need to check it again. I need to recheck. So till I feel satisfied. Okay. There is also perfectionism. I must ensure that my paper does not even have a single grammatical error. I must clean my kitchen such that there is not even a single speck of dirt anywhere. So if dirt is there, it might cause contamination to somebody, or they might get ill, and I might become responsible for those things. Okay, so these are some of the appraisals that you see. Now I'm going to present a case, okay, that we have seen, not necessarily one case, maybe it could be a combination of cases also, but I put it in a case format. So I want you to listen to this carefully, because which is going to clarify lot of things that we have discussed till now. Okay. Now this is a case of 30-year-old homemaker who has been harboring thoughts of harming her child for the past 5 years. So we are basically, remember, we are dealing with thoughts. Her daughter is 7 years old and is going to school. She fears that she may stab her, strangulate her, throw her off the balcony. She realizes that her fears are illogical, but what if thought makes her extremely anxious, and had led her to employ various strategies to prevent dreadful consequences. She has stopped entering her kitchen when the daughter is around, and makes sure that she hides all sharp objects, including knife, once she is done with her kitchen work. If she requires to use kitchen knife when her daughter is around, she makes sure to lock her kitchen door or insists her husband or mother to be around her. Similarly, she has stopped sleeping with her daughter, doesn't use pillows lest she suffocate her child with pillows, has closed balcony of her flat permanently. To handle her anxiety, she tries to suppress her thoughts unsuccessfully, keeps arguing in her mind how she actually is good and affectionate mother, prays God repeatedly for forgiveness, reassures herself that she has never harmed her child. Her husband and mother they are tired of reassuring her. In essence, she has stopped caring for her child because of fears, and in fact avoids being with her daughter alone. She suffers from intense guilt that she harbors such aberrant thoughts, wonders if she is basically an evil woman, and therefore she gets such thoughts. She has thought of killing herself and has been depressed for some time. Okay, so I want you to, I mean, at least if you can tell, that is good. So tell me, what are the obsessions that she's having? What are the examples of obsessions? What are the examples of compulsions? What are the examples of avoidance behavior? What are the examples of family accommodation? And whether she has any insight. So if you can identify these five things, that is good enough from this case. So what are the obsessions? What are the compulsions? Does she have any insight into the illness? Is there any avoidance? And is there any family accommodation? If somebody wants to say, you can say, or at least you can think about those things. So as you can see, it causes significant distress and dysfunction in the individual. Okay, so whatever the previous slide that we have talked about, like for overestimation of threat, thought action fusion, okay, over importance of thoughts, okay, all of them are present in that lady, so we have to work at that level also. Okay, now there is one more particular technique which is considered gold standard technique in treating people with OCD. We call it ERP, exposure and response prevention. Exposure and response prevention. Okay, so we expose, for example, we expose this woman, or we ask this woman to stand uh, with her child. okay, with knife in her hand, okay, stand with her child with, so she would experience intolerable levels of anxiety maybe, okay, or she might experience higher levels of anxiety, but she needs to stay with the anxiety instead of performing compulsions or avoiding those things. So what happens is, through a process of habituation, she will learn to understand that her beliefs are irrational. Okay, so this is not as easy as I said. It involves lot of negotiation, lot of education, lot of motivating the client. But this is only one of the ways where it helps the client to disconfirm the beliefs that she already is having. Suppose if she keeps avoiding those things, there is no way that she can learn, that she can by reasoning or by way of educating, that this is really not dangerous, because she herself knows that these are all illogical, but she cannot stop. So only when she experientially learns it through a technique called ERP, then she will be able to understand. It helps her to have get habituated to these things, and she will be able to do those things. Okay, so this is what case that I wanted to talk about. And now we'll look at what is the course and outcome of this even after treatment also. Okay, so I'll show you few studies. Like for example, this is a study which is a 40-year follow-up of about 144 clients. Okay, to see whether they have improved or not. As you can see, after 40 years, the recovery, complete recovery, is there only in 20% of people. Okay, complete recovery is there in 20%, and there is subclinical recovery. There is a recovery, but not complete recovery in 30% of the people. Okay, but 50% have not improved at all. 50% have not improved at all. And there is also one more study. I mean, there are different studies. If you see what is the percentage of people who have completely recovered or fully remitted, so it changes from study to study. But as you can see, but there are significant number, even in the last study which you see, which says there are 65% of the people who are completely remitted or completely recovered. Even there is 35% of those who do not benefit from it. But one good thing is at least 65% would benefit from it. Okay, so there are multiple factors that are causing, or maybe that are reason for good prognosis or bad prognosis. We will have a look at them. Okay, so what are the conclusions of these studies? Is OCD is a chronic disorder. Only 30 to 50% improve, but there are reasons why others would not improve. Okay, so what are these predictors of outcome? What predicts who improves, who do not improve? Okay, so one of the predictors, as we have discussed, is if they have poor insight. If they see these thoughts are real, if they don't see them as unreasonable, then that indicates that they have poor insight. Okay, so what are the predictors of this outcome? So if they have another psychiatric condition, so then the chances of getting better is low. And if they have any other personality related issues, then the chances of getting better is low. If they have poor insight, then it is associated with poor outcome. If they have early age at onset, that is before 18 years, and sometimes later age at onset after 40 years also, they have poor or like a poor outcome, associated with poor outcome. And if they have to start with, when the treatment is started, if they have severe illness when they are starting the treatment, that is also associated with poor outcome. And certain particular type of obsessions like hoarding, symmetry, magical thinking, they are associated with poor outcome. And what is associated with good outcome? The longer they are present in the treatment, then there are chances of getting better. And before the onset of their treatment, okay, before the onset of their treatment, if they have not gone through any other forms of treatment, like that is, they are coming to you for the first time, okay, and you are providing an effective treatment, okay, then there are chances of getting better. But if they have already gone to many other people and who have not used proper ways of treating them, so then there are chances that they might not get better, they might not get benefit from your therapy. So it is very important to use evidence based therapies with these people, because you get only one chance, because after that they become more and more resistant. Okay, because if you are not using evidence based treatment, instead of helping them, it can increase their illness. You're using your own form of illness. Okay, for example, persons, people who are not aware of these things, they might tell them, why don't you try to stop your thoughts, why don't you control your thoughts? Okay, so they might do that, but it can increase or it can exaggerate the illness. So there are particular ways in which you need to treat the uh, uh, patients with OCD. And some psychologists might even teach them relaxation techniques. Okay, relaxation is counterproductive, it does not work with OCD. It can increase, it can be used as a compulsion in OCD. So relaxation procedures also would not work. So the effective or gold standard technique that is used for OCD is called exposure and response prevention, along with cognitive appraisals, or or restructuring of cognitive appraisals. Okay, yeah. So I think that's all. I'll stop my presentation here. If you have any queries, please go ahead and ask me. Thank you.
Thank you, Doctor, for taking your time to load us with so much of information. Participants, if you have any questions, please do keep thinking about them, and we can post up in the chat box so the doctor can take care of it. For those who have joined us for the first time, Deborah RIse movement (DRM) is a movement that was started in during the lockdown, and it was started in order to address various questions, various topics that are essential for people both inside and outside the church. So, relevant topics which are helpful and which will help us be a better person is what DRM looks at, and it looks to address it by bringing in top-notch people to deal with that. So, moving to the time of Q&A, folks, if you have any questions, please do post it up. Sir, Doctor, we have one question, and it says, "Sir, can you explain more about ERP?" Or
Okay, okay. Uh, so ERP, as the name suggests, exposure and response prevention. Okay, it works on a principle of habituation. Okay, now how does it work? Usually, what happens is, when somebody is anxious because of an obsessive thought, anxiety that is created by an obsessive thought, what they do is they immediately perform compulsion in order to get relief from that compulsion, that anxiety. Okay, now if they perform compulsions, if they keep on performing compulsions, there is no way to know that even if I don't perform compulsions, nothing will happen. For example, you can take this thought, let's say I'll go back to one particular thought maybe. Okay, so if I shake a stranger's hand, then I will contract AIDS. Okay, if I shake a stranger's hand, then I will contract it. So what you do in as part of ERP is you will make them shake hand with somebody. Okay, and when they usually what they do is, when they accidentally shake hand with somebody, what they do is they repeatedly wash their hands till they feel satisfied that it is not there. Okay, they might wash their hands for an hour, 2 hours, 3 hours, 4 hours, as long as 8 hours also. Okay, so now you ask them, uh, uh, I mean, you shook your hands with somebody, but you still didn't get AIDS. Then the reason they give is, because I washed my hands, that's why I didn't get AIDS. So the reason they are giving is their compulsion as the reason, or avoidance as the reason. Because I didn't shake hands with this person, I didn't get AIDS. So avoidance and compulsions became they become hindrances in disconfirming their belief that even if I shake hands, then I will contract AIDS. The only way they would learn, because they already know logically that it may not be true, only way they learn is, even if they don't do it and they go through the anxiety, they go through the distress, anxiety subsides on its own. Okay, so what you do is you make them shake hands. Okay, and help, so you tell them that you go through the anxiety without performing compulsions. Okay, so now how it is done, you construct a hierarchy of all the situations which they avoid. For example, so you may ask that woman, the case study that we have seen, you may ask that woman, so start using knife when your child is in the bedroom. okay, not when she is immediately near to you. Then slowly you ask her to use that when the child is in the hall. So then you ask her to use that when the child is in kitchen. So now when she is in the bedroom, the anxiety that is caused is lesser compared to when the child is in the hall, and it is lesser compared to when the child is in uh, uh, kitchen itself. So you construct a hierarchy of all the situations that she avoids, or that where she performs compulsions, and you start where the anxiety is moderate, not at a place where it is severe. So you expose her to the situation, and you tell her that you need to uh, tolerate the anxiety that is created by that. Okay. So and as she tolerates the anxiety, it might take 1 hour, it might take 30 minutes, within which that anxiety would come down slowly. So she gets habituated. She also learns experientially that even if I shake hand, it doesn't, I mean, it doesn't cause AIDS. Okay. So something like that. Even if I use my knife when the child is there, nothing would happen. So whatever I feared is not going to happen. So but it requires a lot of negotiation, okay, lot of motivation. And you will also tell the client that you may have to go through some distress, you may have to tolerate some anxiety, you may have to tolerate some uncertainty. Okay. So then even before that, you would educate them about what OCD is, what thoughts are, and what appraisals are. So once you have done with all those things, you move on to this particular phase. Okay. And it is done slowly, and it requires a lot of patience. For us, it is not easy to negotiate with the client. If you put them under a lot of anxiety, they might even discontinue the therapy. Okay. So ERP basically involves exposing them to the feared situation and stopping them from performing compulsions. So it works through a principle called habituation. Okay. Yeah.
Okay. Thank you, doctor, for adding on that question. We've got a good bunch of questions that are popping up. So the next question is, sir, how do we identify the level of OCD?
Okay, so level of OCD is, there are certain scales that are available. One of the scales that I mentioned is, one of the instruments or tools we call it, is mentioned is a standard or gold standard instrument is Y box, Ale Ale Brown Obsessive Compulsive Scale, Y box. Okay, so it has items for, let's say, how much time you take in obsessive thoughts, how much you spend time in for performing compulsions. Okay. And you also assess the insight there. Okay. You also assess whether they try to resist it, how successful are they in resisting their thoughts. So there are a lot of questions where you explore different facets or different dimensions of this illness. Okay. And which would give you an overall understanding of how severe is this illness. So two things that you would look for is the amount of time that they spend, the amount of distress that they are experienced, and the insight that they have. So these three would give you a fairly good indication of the severity of the illness.
Thank you, doctor. Can you please add a comment on what if a person has guilt that causes or leads a compulsive behavior of washing of hands regularly?
Hmm. So see, I mean, now we talked about distress, we talked about anxiety. It can be guilt or it can be disgust also. Okay. So your thoughts can, for example, like this woman has thoughts like, I might kill my child, or she would think that I'm getting these thoughts means I'm really intending to kill my child. That would create guilt. It would create guilt because I have already given so much importance to the thought, because I believe that getting thought is equal to me being an evil woman. Okay. So that is an appraisal. So you need to educate them about saying that, see, you are getting these thoughts because of OCD. It doesn't have to do with it. It doesn't mean that it doesn't mean that there is a problem in your character. It doesn't mean that you are a evil woman. You're getting these thoughts because there is a dysfunctionality in your brain, or there is a neurochemical imbalance. Okay. What you are supposed to do is you have to ignore them. Okay. Not to be given importance to those things. So there is a lot of use these cognitive exercises also will happen along with ERP. Okay. Exposure response prevention therapy. Yeah.
Thank you, doctor. The next question is, does OCD develop due to a bad and horrible past?
Yes, yes, it is definitely associated with this horrible past. When you say it could be the abuse that one experienced during the childhood, or it could be being in the family where one of the parent is psychiatrically ill, or having maybe harsh parenting experiences, neglectful parenting experiences. All of them are associated with development of any psychiatric disorder. It may not be OCD. Which form it takes, we cannot predict, but uh, most of the psychological problems or psychiatric disorders are associated with pathological experiences or adverse experiences during childhood.
Okay, thank you, doctor. The next question is, two people asked this particular question. Can OCD develop into schizophrenia if not treated?
Uh, I am not aware of any studies that particularly uh, what do you call uh, changing OCD into schizophrenia, but sometimes if the OCD the severity of OCD is high, that means they would definitely lack an illness. Sorry, they would definitely lack insight. Okay, so they believe these thoughts as true. So they go to such an extent that they become delusional. Okay, so that they will not be able to see this as unreasonable thoughts or irrational thoughts. They believe them as true thoughts, or sorry, true or realities, reflection of realities. I really the mother might believe that I really wanted to harm my child. Okay, I'm a bad woman, so she might commit suicide, or she might attempt suicide. So it is a delusional level, but usually that does not happen with person with OCD. So OCD can turn, if untreated, if there are other issues in the family, for other issues with the person, it can turn into a psychotic disorder. May not be exactly schizophrenia, but one psychotic disorder. Okay, but I'm not aware of OCD trajectory moving into schizophrenia.
Thank you, doctor. The next question is, in the case study that you had shared,
Hmm.
what would be the cause for the mother to think in that way to harm a child?
Okay, so here we did not explore the cause. As I said, there are multiple causes again. When I was talking about causes, I told that I mentioned that it is not easy to pinpoint and say this is the cause. Okay, so for that we need to check the family history. Okay, we need to check whether she is going through any other stressors. Okay, so it can be anything. So only when we look at those things, it could be biological also. So maybe one of our family member is already having some psychiatric illness, or so it can be anything, or it could be a neurochemical explanation also.
Okay, thank you, sir. The next question is, if someone is getting married and comes to know that their partner has symptoms of OCD,
Hmm.
could it affect their relations, and what should they do in order to bring a better marital life?
Okay, so one of the important thing is, if you remember the case that I've presented, it would definitely affect in a way that if you do not have, as a family member, if you do not have proper understanding of the illness, you might accommodate that illness. Okay, initially it may be okay, but over a period of time you may have to do everything for the person because they would completely avoid it. So for example, this woman used to ask mother and as well as husband to reassure her that I didn't really harm my child, right? Okay, so that reassurance can go up to maybe 100 times, 500 times in a day. Or she might continuously call husband, and she might continuously ask husband, did I do anything wrong? Okay, so in that way it can definitely affect, and it can also cause a lot of burden to that particular family member, and she might completely stop taking care of the child. Okay, so in that way it definitely has an effect. And one of the important ways you deal with is that we include this is not an option, This is compulsory, that you have to include family members as part of your treatment process, therapy process. You have to educate them properly. And so you have to include family as well as the client, and you tell the client they are not going to accommodate your behaviors, because if they are going to accommodate your behaviors, your illness would continue to your illness will continue, or it will be maintained. So from now onwards they are going to stop accommodating your behaviors. Okay. And we also tell them that she is going through a lot of anxiety. You need to be understanding, at the same time gently saying no to her requests of performing compulsions on her behalf. Okay. So they should understand, with proper understanding, proper empathy, we should deal with the client.
Thank you, doctor. We've got the next question. Is OCD completely curable? If yes, will it automatically cure social anxiety associated with it?
Mhm. Let me have a look at the question.
Can I read it out
Yeah.
again?
So as you have seen, when I talked about course and prognosis of the OCD, about 50% of them only get cured completely. There are 50% of them, they may not benefit from any form of therapy. Okay. So as long as 40 years they were followed up, and it was understood that only out of them only 50% of them have improved completely. I mean, it's not even 50, 30% only have improved completely. So yes, it is completely curable in some cases. In some cases it may not be curable. It is because of other reasons that I talked about, having other illnesses or having personality issues. So all those things. Okay. and and I didn't understand this question in the sense that social anxiety has nothing to do with OCD. Social anxiety is a completely different disorder, and somebody with OCD may also have social anxiety. Okay. Yeah. So social anxiety is a completely different disorder. Yeah.
Thank you for clarifying that, doctor. The next question is how to deal with a person who is a victim of sexual abuse and also who views sex as a dirty and undesirable thing in marriage.
Okay. So now is it in the context of OCD? Okay. Now if you feel that there is an abuse, you need to do something called, along with and you see, many people might have had abuse in the past, but it may not impact them currently right now. Okay. So but if you feel that that is something that is playing a major role in their current circumstances, in their current life, so you need to do something called trauma sensitive therapy or trauma focused therapy. Okay. Where you need to address those issues also. Otherwise just doing this therapy would again bring back other forms of illness, because the trauma was not resolved.
Okay. Okay. Thank you, doctor. So the person who asked this question has asked, could you suggest some website or books or some materials that could help?
Okay. See, one of the books that I mentioned is Brain Lock. Okay. There are many books on, I don't remember the authors, but there are books on cognitive behavioral therapy for OCD. Okay. So cognitive behavior therapy for anxiety disorders. So initially it was considered one of the anxiety disorder. Now it is made into a different spectrum of disorders. Okay. So you can read any book on cognitive behavior therapy for OCD.
Okay, and it will apply to the same question of the person uh, who has symptoms of OCD in a marriage, right?
Mm.
It can help, right? Okay, thank you, doctor. The person who asked the question is OCD curable, as asked again. If untreated, will the person have to live with the symptoms all their life?
Uh, I mean, if you ask scientifically, the research is done maybe as long as 50 years, followed them up. So if we consider 50 years as whole life, yes, they have to live with those things. Maybe some, we don't know, some, let's say, different experiences might change that. But as long as if left untreated, it is unusual that they get better.
Thank you, doctor. The next question is: does pumping ourselves with positive thoughts help us come out of OCD and negative thoughts?
Okay, so first thing is, when you deal with any thoughts that come to your mind, understand that any thought can come to your mind. Okay, and not to see thoughts as realities. Thoughts are not fact. The fact that thought came to you, it doesn't mean that the thought is true. It doesn't mean that thought is fact. Okay, you don't need to own the thought. You don't need to own the thought. For example, I mean, as some of us are Christians. See, Satan can put certain thoughts in your mind. Okay, if you own, let's say Satan told you that I mean, you're planning to kill your child, and you own the thought and say that yes, I am planning to kill the child, and again Satan would say that since you are planning to kill the child, that you are a bad woman, and then you own it and say yes, I am a bad woman because I have this thought. So the meaning that you attribute, how you deal with the thought. Okay, so I usually give an example. Let's say that I am going on a road, I happen to watch a movie poster, and there is an actress, and I might get a sexual thought because I was exposed to that. Okay, now I have few responses to that. One response is I can ignore it, I can go on my way. Other thing is I might fantasize and develop that thought. Okay, other response would be I might start thinking that, so I got this thought, that means I am a sinner, I'm a very bad person, maybe I really have this what do you call sexual intentions in me. So when you start doing that, you develop guilt. So first you need to understand, the moment the thought comes, you don't have to own it. Okay, you just notice it and ignore it. So one of the ways that we tell clients that you're getting these thoughts because you have OCD. Okay, because you have structural abnormality, or because there is a neurochemical imbalance. So that you're attributing the presence of these thoughts to this thing, but not to yourself. You don't personalize in saying that maybe my character is bad, maybe I am bad. You don't give that meaning. Okay, yeah.
Okay. When you were talking about Satan, provoking thoughts and all that, I was just thinking, does he has the ability to plant thoughts in our mind? Does the evil one?
See, one way, only one way that Satan can touch us is to deceive us. Is a
Okay.
deceiver. So if you believe, you will make it true in your life. If you keep on meditating on what it puts you puts, or what it tells you, that lies, Satan is a liar, Satan is a deceiver. If you start believing those lies, you are already deceived.
Okay.
Okay, the only way that it can impact us is that planting lies, or maybe telling lies. Okay, then if you believe them, then you will get affected.
So he can plant those thoughts through various means, like how you said, the poster and other.
Like the same thing that Jesus Christ has experienced in the wilderness.
Okay.
Yeah.
Cool. So we've dealt with all the questions that has come up in the chat box. And for those who have joined us for the first time, I've put up a few links in the chat box. Please do go to them and also note down our helpline number in case you have any queries or more issues to deal with. Thank you everyone for taking your time for being a part of this talk. Once again, Dr. Vidhya Sagar, we thank you very much for being a part
Thank
of
you.
this
Thank you.
talk. We're
Yeah.
glad.
Yeah. Thank you.
We
Thank
Thank
you,
you.
Dr. Vidya Sagar. It's very useful. Thank you so much.
Thank you. Thank you.